My name is Waligora, and I'm the Manager of Health Reform Initiatives for EverThrive, Illinois. Today I'm going to talk about the Affordable Care Act, or Healthcare Reform, Obamacare, whatever you may call it. I'm going to call it the ACA, and the effect that it's having in communities across the state of Illinois and across the country, and many of the policy decisions that have shaped implementation and the decisions that we have yet to make, which could shape implementation even more drastically. Just a little bit before I start about the organization, EverThrive Illinois is a nonprofit organization dedicated to improving the health of women, children, and families across the state of Illinois. We do this in a number of ways, including but not limited to influencing and shaping public policy, spreading education on policy, and acting as an advocate for those policies that help the people of Illinois. We have a lot of different priority areas. You can get more information about EverThrive on our website. There's information on the last slide. For today's presentation, we'll talk about some of the basic provisions of the ACA, the Affordable Care Act, Health Reform, Obamacare, and talk about how that's going to impact or is impacting the people of the United States. But we'll also talk about the policy decisions that have been made and will be made that really have a drastic impact on policy and the way the policy is shaped, including the recent Supreme Court decision on the Hobby Lobby case, which will have a dramatic impact. Finally, I'll share a little bit of information on resources and tools to enroll in coverage, to learn more about the Affordable Care Act, and to think about how it may impact you, your families, or people that you're working with. So before we jump into the law itself, I want to provide a little bit of background. It's been a long time since the Affordable Care Act was passed, right? It was signed March 23rd of 2010. It feels like ages and ages ago. It's about 4 years ago. And a lot has happened since then. So I think it's important to step back, remember what was happening in 2010, and to set the context. In 2010, the insurance industry, and before 2010, the insurance industry was largely unregulated. So when you think about large industries that impact a lot of people, you can think of things like banking or transportation. Insurance industry was like that, except for it had very little regulation, unlike banking and transportation. As a result, access to health insurance was unpredictable. If you didn't have access through your employer, odds are you don't have it at all, right? Anybody could go to an insurance company or go to a broker or agent and try to purchase coverage. You could be denied for a host of reasons or for no reason at all. You could be charged exorbitant amounts in your monthly premiums or your annual deductibles, and it really created this spotty access, and it made it so that functionally the only access to health insurance is through an employer, or if you qualify through Medicaid, Medicare, or other public health insurance programs. There was no guaranteed access. So I mentioned that folks could be denied. Of course, the number one reason we think of is pre-existing conditions. All of this is changed by the Affordable Care Act, and we'll talk about that in a little bit. Unpredictable quality. So insurance providers really had free reign in most cases to provide or not provide whatever services they wished. Sometimes these were negotiated by our employers, one of the reasons people benefit, another reason people benefit from having coverage from their employer. But overall, there were no national standards, which meant if I was purchasing this product, I had no guarantee that it was going to cover some of the most basic health services, like emergency room care, prescription drugs, or hospitalizations. And finally, there was unpredictable value. So this is a product we were all paying for if we could get access to it, but our costs could vary on factors outside of our control. For example, whether or not we're a woman. They could vary based on our age, and they varied significantly. Before the Affordable Care Act, on average, older adults with private health insurance were paying 9 times more than younger adults with health insurance. Of course, people with pre-existing conditions were routinely charged much higher premiums for the exact same care, and even people working in certain industries. So a great example is that I have a cushy desk job, so I pay a premium. My dad is a construction worker, so he's out, he's in a higher risk field, he's moving around all day, he's working with tools, so he would pay my premium times some amount because of that job. And of course, there were no caps on cost, but limits on care were okay. So I could pay tens of thousands of dollars, and people often did pay tens of thousands of dollars for care, but then my insurance company could cut me off once they've paid out a certain amount. So there were unequal protections across the board that resulted in a lot of people being very unhappy with their health insurance and also feeling like they had no control. It really was an industry that didn't provide much protection for consumers, and that's part of what the Affordable Care Act set out to address. And this is the part that sometimes gets lost because we talk about the Affordable Care Act in terms of the number of people insured on the marketplace. But these consumer protections are really important. As long as we're talking about consumer protections on the marketplace, or the number of people insured in the marketplace, it's important to talk about the uninsured. So we had at least 47 million uninsured people in our country at the time the law was signed on March 23rd, 2010. It's 18% of the population. Now, of course, that's on average. In some places or in some demographics, we have much, much higher rates of uninsurance. Of course, Latina and Latino families are a great example, very, very high rates of uninsurance. And then, of course, lower income families also have very high rates of uninsurance because of the costs associated. 129, this should be million, not 129. 129 million people have had pre-existing conditions. So we heard so much about pre-existing conditions when the law was being passed because it was a compelling argument for passing public policy. But we heard about the scariest conditions. We heard about cancer and heart disease and AIDS and all kinds of illnesses that a lot of us hopefully aren't going to come into contact with. It skewed perception of pre-existing conditions a little bit in the public. In reality, a pre-existing condition is any condition that you have before you're insured in a particular health insurance plan. I have asthma. That's a pre-existing condition and I could be denied coverage. In almost every health insurance plan, pregnancy or pre-existing conditions or pregnancy or C-section are pre-existing conditions. So my guess is everyone you know was born at some point. And because you were born, there's someone who could be charged more or even denied coverage based on a pre-existing condition. It's likely that 129 million is actually a really conservative estimate of how many people have pre-existing conditions. Of course, we know that there are great disparities in access to healthcare and in access to health insurance. So we know many things about the uninsured, and I have some more information on this in the next slide, but I think the most important is that the uninsured are most likely to be people of color. The main barrier for anyone who's uninsured is the cost of insurance. We heard this again and again and again, that there's just no way somebody who doesn't have employer-sponsored coverage, and even sometimes when they do have employer-sponsored coverage, could bear the cost of health insurance. The uninsured are more likely to delay or forgo care. So in the world of public health, we often talk about the importance of improving health outcomes, and there's two really important things to think about when we talk about this. Health disparities, so the uninsured are more likely to be people of color, but also thinking about improving health outcomes. And the best way we know to improve health outcomes is to give people medical homes, to make sure they get early access to treatment, and ideally preventive care. So when people are forgoing or delaying needed medical care, that drives up the cost of care. It also drives up rates of incidence and comorbidity and mortality and all of those bad health outcomes. So this is really important to think about as we think about moving that. All of these statistics came from a wonderful report written by the Kaiser Family Foundation on the uninsured. It's continuously being updated. There are tons of facts, a lot more than I've gone into here, and I encourage you all to take a look at that. You can find it on their website, kff.org. So more on the uninsured, just to think more about the demographics. The uninsured are more likely to be low income. 53% of uninsured adults have incomes at or below 138% of the federal poverty level. That's important because this is eligibility for Medicaid. So 53% of uninsured people could be eligible for Medicaid under the Affordable Care Act. Less than 1% of uninsured adults have income greater than 400% of the federal poverty level. That's important because anybody with income up to 400% of the federal poverty level will likely qualify for financial assistance under the Affordable Care Act. We're going to talk a lot more about Medicaid and financial assistance, but what's important to know here is the uninsured largely are going to get help paying for their health insurance under the Affordable Care Act, or potentially free health insurance under Medicaid. Most of the uninsured are between 19 and 44 years old. That's because for those under 19, we have the Children's Health Insurance Program, which was passed a number of years ago, reauthorized by President Obama in 2009. That provides insurance to the vast majority of children. In Illinois, our uninsured rate for children is about 3%, so we're doing a really good job there. Of course, people over 65 are likely to qualify for Medicare, so we see very, very low rates of uninsured on that end too. But 19 to 44, when a lot of stuff is happening to your health, especially for women, that's where we see most of our uninsured. 30% of uninsured are Hispanic, 49% are white. So again, thinking about those racial and ethnic health disparities. 1 in 5 uninsured is a non-citizen. So we hear a lot in the conversations about the Affordable Care Act about the importance of reaching immigrant families, and this is why. And finally, most uninsured are in a working family, full or part-time. There's a number of reasons that could happen, right? My employer may not offer coverage. My employer may only offer coverage to the employed person and not to spouses or dependents. The coverage offered by my employer may not be affordable, or I may be working part-time jobs or multiple part-time jobs and don't actually qualify for benefits under the standards established by my employer. I think the other thing that's important to note is most people who are in the 50 million uninsured have been uninsured for a long period of time. So there are more great pie charts on this in the Kaiser Family Report, but what we know is the vast majority of uninsured people have been uninsured for 2 years or more. So there's obviously a lot of people who move in and out, and they're uninsured for short periods of time, 3 months when you change a job, or just over the summer if you're a student. The vast majority of the uninsured are long-time uninsured, which has huge implications for outreach, because it's going to be harder to find them and talk to them and convince them. Has huge implications for health literacy, so we really need to think about how to talk to those folks and get them back into the healthcare field in an effective and efficient manner. It has huge implications for health outcomes. The longer somebody's uninsured, the more likely they are to have serious health problems, and that means it's more important than ever to get them in early and get them into primary care as quickly as possible. So just a little bit of statistics on the number of uninsured. This comes from a wonderful website called IllinoisHealthMatters.org. Illinois Health Matters is a website that has all things health reform specific to Illinois, including this great tool called Visualizing Health Reform, which is American Community Survey data laid onto a Google map. It's fully interactive, but I pulled statistics for the whole state. So in Illinois, we have 1.5 million people who are likely uninsured and eligible for coverage as of January 1st. We have an additional 280,000 undocumented non-citizens. So it's important to note, undocumented people do not gain access to any of the programs or protections granted by the Affordable Care Act. They cannot use marketplaces, they cannot get into Medicaid. So this leaves 280,000 people, a significant number of people, without a pathway to affordable, high-quality care. But when we look at the 1.5 eligible, or 20% of our population, we got 618,000 who are eligible for Medicaid under the expansion. We have 717,000 who are eligible for tax credits or financial assistance in the marketplace. So again, the vast majority of people are getting some sort of help paying for their coverage. And then we have 191,000 who can purchase coverage on the marketplace, but their income is sufficiently high, they're not going to qualify for financial assistance. On Visualizing Health Reform, you can break this data down by other demographics, so we can see gender, ethnicity, veteran status, disability, and age. These are just adults. Like I said, we have 3% uninsured rate for children. That's not reflected in these numbers. Of course, the group we hear the most about in terms of the Affordable Care Act are young adults, people between 19 and 34. They call them the young invincibles because the perception is that people between 19 and 34 have very high uninsured rates. That's not a perception, that's a fact, right? So we can see this here. Uninsured really, really spikes as soon as you hit 19 years old. It comes down as you get older. The perception is that these folks, these young people, are uninsured because they don't want health insurance. They think they're not going to get sick, not going to get injured, and it's a waste of money. I think speaks a lot to perceptions of young people in general, but surveys have been done of these young invincibles and have found that 80% of uninsured people between 19 and 34 say, I do want health insurance, I have tried to get health insurance, I have not been able to afford health insurance. So we know a lot of things are happening between 19 and 34, right? People are leaving school or maybe going to college or graduate school, they're getting married, they're moving, they're joining the military, there's a whole host of life transitions that are happening here, and anytime there's a transition in your life, you're likely to be uninsured. That's why we see this. And then of course, you're making a lot less money usually at 19 than you are at 45. So it's a lot more difficult to afford private health insurance outside of your employer. The good news is the Affordable Care Act finds ways to help these young people and creates many new avenues to access coverage. We hear a lot about young adults because the belief is young adults need to purchase insurance in order to make this all financially viable, and I want to address that for a second. The idea is young adults are young and healthy and we don't need insurance, but we're required to buy it. So we're going to buy this product and we're never going to use it, and it's going to spread out the risk amongst all of the users. While to some extent that is important, it has been significantly overvalued in media coverage of the Affordable Care Act. We have more than met the necessary number of young adults insured to keep premiums stable, not taking into account the many other factors that influence premiums. And I think that narrative really does a disservice to young adults when we talk about the Affordable Care Act as a resource for people to get insurance who don't need it. Young adults need it, people of all ages need health insurance, and the Affordable Care Act is helping all of those folks. So let's talk about what the law does. The Affordable Care Act really is changing the landscape of access to health insurance and indirectly impacting the healthcare delivery system. So this is a 2,000-page law with tens of thousands of pages of federal rule, state laws, state rule. It would take forever to talk about everything this law does. But what I am going to do is talk about the most basic provisions, the things that are most commonly talked about, the things that have the biggest policy implications, and those provisions that are most likely to impact you or your family or friends. So at a glance, the Affordable Care Act, as I mentioned, was signed on March 23rd of 2010, though most of the major provisions took effect on January 1st of 2014. Basically, the way it worked is from 2010 until 2014, all of the provisions that actually regulated the insurance industry, so those quality measures, those standards for our insurance coverage, those were taking effect in those first few years. A lot of us didn't realize that because we're used to our insurance changing or we don't really know what our insurance covers. January 1st was when the provisions that brought more people in took effect. So it's when we opened our marketplaces, expanded Medicaid, and created new access. The first 3 years were about quality, the following years are going to be about access, and then we'll throw it all together in the future. So on October 1st of 2013, our health insurance marketplaces opened. On January 1st of 2014, Medicaid was expanded in about half of states across the country. We're going to talk in great detail about these two. Last thing I do want to talk about is the requirement to purchase insurance. This is the only place that I talk about it, so I do want to take a moment. Under the Affordable Care Act, as hopefully everybody knows, individuals are responsible for purchasing health insurance beginning on January 1st of 2014. You must carry health insurance throughout the year with a 3-month grace period to account for those life transitions. So you must carry insurance really for 9 months out of the year. If you have not done that, you may be required to pay a penalty. Now, if you're uninsured, there are a lot of exemptions to the penalty because we don't want to penalize people who have made a genuine effort or simply could not afford health insurance. So if you've had a hard year financially, so if you filed bankruptcy, if you were homeless, if you had very high medical expenses that have made it difficult for you to pay your premiums, if you've had fire or flood or natural disaster, there's a whole list of exemptions for hardship exemptions. There are exemptions for people who are incarcerated. There are exemptions for people who have been out of the country for a long period of time. All of those would allow you to be uninsured without paying the penalty. But for the most part, most people who are uninsured for more than 3 months in 2014 will have to pay that penalty. In the first year, because we know there's an education gap, the penalty is very low. It'll be $95 or 1% of your income, whichever is higher. There is a cap on the penalty, so Warren Buffett isn't going to be paying out hundreds of thousands of dollars. The cap is around $2,000 this year. If you have an uninsured child in your family, you will pay the penalty for that child as well, but it'll be half of the adult penalty. In future years, it will go up. After 3 years, it'll level out at 3% of income or $600 and some dollars. So it will be higher. It will never be more expensive than purchasing insurance. So it's important to know it's just a small incentive. We know that people prefer to get something when they pay, so we know it sort of works to motivate people to get insured. There is a penalty for employers as well. This is much more complicated and it's on a delayed implementation schedule in order to make sure that we can monitor the impact on employment. All of this is modeled after a law that was passed in Massachusetts in 2006 under Governor Romney. The hallmark of that law was the expansion of Medicaid, the establishment of a marketplace, Massachusetts Health Connector, and the implementation of an individual and an employer responsibility provision, which included a penalty. What we saw there was a lot of fear, just like we're seeing now, and then not a whole lot that came out of it. Things sort of leveled out. Of course, that was 2006, so then the recession came and all of our data is skewed. So let's talk about how the law impacts the insurance industry, since we know it was such an underregulated industry. Of course, the one most of us probably know is that no one can be denied coverage based on a pre-existing condition. So as I talked about, this includes a whole range of conditions well beyond cancer and AIDS and the really, really scary ones. So this is an important protection for all of us. Under this provision, you cannot be denied coverage, you cannot be charged a higher premium, you cannot face an exclusionary period where they cover everything but your pre-existing condition, and you cannot be dropped from coverage because you become sick. So this really makes sure that those of us who need insurance the most have access to it, and we have regular, continuous access to insurance. Another point that a lot of people know about is around extended dependent coverage. So under the Affordable Care Act, young adults can stay insured until their 26th birthday on their parents' insurance if they wish. What a lot of people don't realize is that young adults can stay on regardless of student status, marital status, tax status, or place of residence. So the example I give is my sister. My sister graduated from college a few years ago. She's 25 years old. She's married. She's a small business owner, and she just had her first child. My sister is covered on my mom's health insurance. Her son had to get his own coverage, but she has maintained coverage with my mom, and that's been huge because she really could not have maintained health insurance coverage while everything else was happening. It's also important to know that veterans are actually able to stay on their parents' health insurance until age 30. A lot of veterans are returning from service in their mid-20s. We want to provide some extra stability in that transition. So here are some of the points that are lesser known, so I'll talk about these. Of course, the most important is cost. Like I said, the number one barrier for the uninsured is the cost of health insurance. So the Affordable Care Act provides financial assistance, which we'll talk about, but it also establishes some rules for how premiums are calculated, right? So premiums are our monthly costs for having health insurance. And in the past, those were based on a large number of factors. There was no national law which established the factors that could be used. Some states had established their own. Illinois did not have many protections. So under the Affordable Care Act, that formula has been shrunk way down to include only 3 factors. So your premium can vary based on your age. Older adults can be charged more than younger adults because there is a healthcare cost associated with aging. But there's a limit, only 3 times more than younger adults, which is 1/3 of the increase most older adults were facing before. There is something called geographic rating, so your premium can vary based on where you live. This is not the north side of town versus the south side. This is drawn along county lines, and in some cases includes more than one county. Geographic rating areas are not a new idea. We've used them for a long time, and they reflect the differences in cost of accessing care in certain parts of the state and the country. This is actually really interesting. So we know that there's huge variations in the cost of certain services or benefits depending on which hospitals you go to. Sort of intuitively we know this. But until the Affordable Care Act came along, we had no data on this. Last year they finally released some data from large hospitals that showed us the scope of the disparity in cost, and it is significant. The Affordable Care Act has other measures that are helping us to explore this issue, and will be a huge public policy opportunity in the future to think about how to control those costs. And it will be the most important next step for us to take. But your cost can vary based on where you live. There are 13 rating areas in Illinois. The most expensive is actually downstate, where it's a lot of rural providers. And the cost difference isn't huge, though it is noticeable. And finally, your costs can vary based on whether or not you use tobacco products. So the question on the application is, in the last 6 months, have you used tobacco products 4 times per week on average or more? If you answer yes, you can be charged 1.5 times more than someone who answers no. None of these things are required. So an insurance company does not have to rate based on age or location or tobacco use. They may. What we're seeing is tobacco rating is not at 100% yet. So some of the companies are charging a little bit more for tobacco use, but they are not charging the full 1.5 times more. Talking about public policy issues, the American Cancer Society is actually opposed to tobacco rating because we find that it does nothing to affect the rates of smoking or tobacco use among people. And that's really what we want to do, right? We want to improve health. It's much more effective to do things like cigarette taxes, which impact the consumer right at the time that they're using a product, rather than a small increase in their premium that they may not understand is related to that. Essential health benefits. So I talked about how we didn't have any standards for our coverage, and that's what the essential health benefits really are. So I'm going to skip ahead a slide and we'll come back. So the essential health benefits are 10 broad categories of coverage laid out by the federal government which established a standard, a minimum standard, for all health insurance plans in the country. So it includes, and I'll read them out. There's no definition for these, or for most of these. The federal government really just laid out the categories. So we've got prescription drugs, rehabilitative and habilitative services and devices, emergency services, maternity and newborn care, preventive and wellness services, including chronic disease management, pediatric services, including dental and vision. Dental and vision are not required services for adults, only for children. Mental health and substance use disorder services, hospital visits, ambulatory patient services, and laboratory services. So what the federal government did is they established these categories. They only gave definition to a few. They specified that maternity and newborn care means prenatal care, labor and delivery, postpartum care, and early newborn services through the first year. It might seem like they didn't need to do that, but only about a third of individual market plans before the Affordable Care Act covered any of those services. So they wanted to be a little bit more prescriptive to ensure that women had the full scope of services they needed. They did specify a lot with prevention and wellness. So under the Affordable Care Act, under the Essential Health Benefits, the federal government laid out a very specific set of services which must be covered for all people, a set of services, additional services which must be covered for children, and a set of additional services which must be covered for women. Most of these took effect in 2010, and this is so specific that it actually says these services, all of these preventive services, must be covered without cost sharing. Now that list was established by the U.S. Preventive Services Task Force and will continue to be updated. So we will get more services added here and potentially could have services removed, though that would be much less likely. In 2012 is when the women's health services took effect, which are really relevant as we just had a big Supreme Court decision this week regarding women's health provisions. So the women's health services is 8 services that must be covered for all women. And it includes things like breastfeeding support and supplies, screening for interpersonal and domestic violence, which is going to be critical. It also includes coverage for the full range of FDA-approved birth control for any reason. And it's specified like that so that women do not have to go to a provider and say things like, I have really bad acne or really bad cramps to access basic health care. It also says the full range of FDA-approved birth control so that women have access to many different methods because it can be very difficult to find a method that's safe and effective and comfortable for a woman to use. Now, what happened with Hobby Lobby and many other companies, at least 40 companies have filed cases similar to the Hobby Lobby case, is that Hobby Lobby is owned by a small group of very religious people, and they felt that providing coverage for the full range of FDA-approved birth control ran counter to their religious beliefs. And in fact, in the Hobby Lobby case, they are opposed to 4 forms of birth control, 2 IUDs, an implantable, and Plan B, the morning after pill, because they believe that those cause abortions. Now, what we know is that's not the case, but we do know that this is a widely held religious belief. So they argued to the Supreme Court that as a corporation, this requirement to cover a service they didn't support violates their First Amendment right. So the Supreme Court had to decide whether or not corporations have First Amendment rights, which are afforded typically to people, and whether or not provision of birth control is such a significant violation that there should not be an accommodation made. And they came out mostly in favor of Hobby Lobby. What the Supreme Court said is Hobby Lobby does have the right to exercise First Amendment rights, right? So they do have the ability to say, we take these rights the same way a person would. But then they had to decide whether or not birth control was an important public health issue or significant in violation of those religious rights. So what they decided is the most important part. They said that it is in fact a large enough violation of religious rights that there should be an accommodation made. They said other services, which are sometimes objectionable to certain religions, like immunizations and blood transfusions, should not be considered objectionable enough to prohibit coverage. So they limited, or attempted in the language of this decision, to limit the decision only to contraceptive coverage. They said that there are other ways for the federal government to ensure women have access to care, and in fact, there's already an accommodation for religiously affiliated nonprofit employers like hospitals and universities. This accommodation says that that employer can file for an exemption They do not have to provide coverage for birth control. However, their insurance carrier will pay for that coverage if a woman chooses to use it. There are huge problems with implementation of that accommodation. We've been tracking that over the course of the year, and we're seeing a lot of cost barriers to women who fall into that accommodation. And as a women's health organization, we're concerned about using that accommodation, but we're happy because the decision, while it was mostly in favor of Hobby Lobby, did not get rid of the requirement to provide birth control and health insurance. The only other service that was specified by the federal government is mental health and substance use disorder services. And they didn't say exactly what services should be covered. They just made clear that services should be covered and that these would be covered at parity with medical coverage. This may be the most important thing that the Affordable Care Act does. It's going to create access to mental and behavioral health services for millions of people and could be huge in reducing the stigma associated with those services and helping people who are in great need. I think we could see some really interesting things over the next 10 to 15 years as a result of this. So all of the other categories are undefined. The law just says what you see on this screen. What the federal government did is ask state governments to pick what they call a benchmark plan, and that benchmark plan becomes the true standard. So states looked at existing health insurance plans, assessed their coverage under each of these categories, substituted where they needed to, and sent that choice to Health and Human Services, who then certified those decisions. If states did not want to engage in making this choice, and about half of states did not, there was a default selected for each state. So each state does have a benchmark plan. In Illinois, our benchmark plan is a Blue Cross Blue Shield plan. It's called Blue Cross Blue Shield Blue Advantage for Entrepreneurs. It's a small group plan, and we added some All Kids Dental and Vision. All Kids is our children's health insurance program. It's middle of the road. This is actually a really complicated decision because you want to provide great services as a minimum to everybody, but every service or benefit you add is going to increase the costs. So we wanted to be conscious of this. States can select a new benchmark plan every 2 to 3 years. So we'll be having these conversations again in 2015. So coming back to talk about our last points, the Affordable Care Act eliminates the caps on lifetime and annual limits on care. So before the Affordable Care Act, we had people running into lifetime limits that would be usually capped at $5 million. Once your insurance company has paid out that much, they don't pay anything. For most of us, this is never an issue. For people with very serious illnesses or accidents, this is a significant issue. Best example are children who are born prematurely. Premature infants are likely to reach these lifetime caps in the first 5 to 10 years of life. And that puts a significant barrier on those kids who can never get coverage under that plan again. When that coverage is tied to mom's insurance or dad's insurance or dad's employer, it can be very difficult to change. Annual limits were much lower, typically in the $1 to $2 million range. Again, most of us didn't come up on those, but what would happen if we did is our insurance companies would stop paying our bills for a period of time and create a significant barrier to care. For people in low-wage jobs, this is actually really important. So low-wage jobs typically don't offer benefits, but if they do, what we found is the annual limits on health insurance benefits for low-wage workers were very low. There's one food restaurant chain that has a presence in Illinois and probably every other state. And what we found is that their annual limit for their health insurance program, which was free for their employees, was $75 a year. Doesn't even cover a doctor's visit. And in some states, like Texas, if you have an offered insurance from your employer, no matter what your income is, you don't qualify for Medicaid. So it actually created a barrier to accessing Medicaid for those low-wage workers. These are both gone. So now we're all protected. We have insurance for as long as we need it. And finally, the Affordable Care Act established funding for a number of funds and research projects. One of the most important for our organization is the Prevention and Public Health Fund, which provides important funding for prevention and public health research and initiatives. All of these funds have limited authorized spending, and we need to look at refunding the ones that are working at various points every couple of years. That obviously is a very significant issue. So it's going to be important for us over time to look at which of these funds are the most useful and think about advocacy campaigns to keep them moving. The Prevention and Public Health Fund has already been threatened many times. So the other part of this, the part that gets the most action in the media, is access to insurance. The Affordable Care Act creates new pathways to coverage. It does not eliminate old pathways. So I think that's important to remember. Before the Affordable Care Act, you could get coverage from your parents, from your employer. You could get coverage from Medicare or Medicaid. You could go through a certified agent or broker. You could go right to an insurance company. You could get it from your spouse. You could get it from your school. All of those things remain in place. The Affordable Care Act adds marketplaces as another resource if people wish to use them, and it strengthens the Medicaid programs in states that choose to participate. So what is a marketplace? Marketplace is an online shopping tool where individuals may shop for health insurance. And by this, I mean you can look at health insurance from many different carriers, many different plans in one place, instead of having to go to the Blue Cross website and the Humana website and the Aetna website. You can just go to the marketplace. You can compare benefits and prices because they're all in one place, and because they're using standard points of comparison. You can actually look from one plan to the next, and instead of comparing apples and oranges, you're comparing apples and apples. You can access financial assistance. This is the most important thing. There are other websites that will pool health insurance carriers. There are other websites that will compare them side by side. You could always call a broker, right? Financial assistance has never been available from the federal government for private health insurance. For the first time we have this for the majority of uninsured Americans, and it's only accessible through the marketplace. We'll talk more about the types of financial assistance in just a moment. And of course you can enroll in a plan, right? So you can go on, you can look at all of the plans, you can pick the one you like best, you can enroll in that plan, you can select your financial assistance and carry on. It's important to think about the types of plans and the number of plans available when we think about public policy. This is going to be a big part of the conversation, and already is a big part of the conversation this year and in the immediate future. In Illinois, in the first open enrollment period, we had 6 health insurance carriers selling 165 plans. All of those plans weren't available everywhere. The county that had the most was Cook County, with 70 to 80 plans depending on your age. This is very difficult because, as you can imagine, there's not a huge difference between those 80 plans. Sometimes there was. They had bronze plans, which had very low premiums and high cost sharing, and platinum plans, which had very high premiums and no cost sharing. Those are significant differences. But aside from those couple of extremes, everything in the middle looks relatively similar. There were tools that popped up. The best is called My Health Plan, Health Plan Ratings, healthplanratings.org. You can go there and put in stuff about your health, about your doctor, and get really specific, and they'll look at the plans for you. For the most part, it's hard to make a decision. In the next open enrollment period, we're going to have 10 carriers selling over 500 plans. So that choice is very difficult. So we need to find a balance in policy between meaningful choice and limiting choice so that people can be better decision makers. It's really hard to make a good decision when you have 500 options. Who can use a marketplace? U.S. citizens can use the marketplace. Lawfully permanent residents can use the marketplace. And lawfully permanent residents do not have to adhere to a waiting period. So typically for Medicaid or Medicare, you have to have been a lawfully permanent resident for 5 years or more. That's not the case with the marketplace. Small businesses can use what's called the shop marketplace. Go to the same website, just use a different portal on the back end. And this is actually where they can shop for small plans, small group plans, if they have less than 50 or 100 employees, depending on the state. In Illinois, it's 50 right now. That will come up. Not everyone who uses the marketplace will get financial aid. So there are income requirements to access that financial aid, but everybody in this list can get onto the marketplace. Undocumented people cannot use the marketplace to purchase coverage even without health insurance. They may be able to buy qualified health plans directly from an insurance. So qualified health plans are the plans on the marketplace. If I was undocumented, may be able to call Blue Cross Blue Shield and ask for one of their marketplace plans, but I could be charged differently. I'm not guaranteed access to that, and it's likely going to be prohibitively expensive. Every state has a marketplace, but half of states are using healthcare.gov, the federal marketplace. The way the law was written, it gave states the option to create a marketplace. If they couldn't or wouldn't, the federal government would step in. I don't think the federal government expected so few states to establish their own marketplaces, but that's where we're at. Illinois has what's called a partnership. So we have a little bit of state work and a little bit of federal work. So we do some things on our own, customer assistance, certifying health plans, but ultimately we enroll in healthcare.gov. So financial assistance. There are two types of financial assistance available on the marketplace. You cannot get these unless you purchase your plan in the marketplace. So even if you go directly to Blue Cross Blue Shield and buy a qualified health plan that they're also selling on the marketplace, you will not get access to this financial assistance. So the first type is premium tax credits. This is available to most people on the marketplace. Your income must be between 100 and 400% of the federal poverty level. So 400% FPL is $93,700 for a family of 4 right now. So a lot of people are going to qualify for this. This brings down the monthly costs of having a plan. So you can think of any tax credit, right? At the end of the year, will file my taxes. I'll say, I earned this much and I spent this much on health insurance, and they're going to give me a tax credit to bring that cost down. What's cool about this is it's advanceable. For the first time ever, we have an advanceable tax credit. So I can go on the marketplace today, tell the marketplace how much I made last year, how much I think I'm going to make this year, submit some documents to verify that if needed, and based on that, they're going to say, this is how much tax credit you're eligible for, and I can take it right now. That means instead of paying the full cost of my plan, I may be paying 20% of the cost, or 50% or 60%, depending on my income. I send my check for that amount, and the federal government sends my tax credit right to my carrier. At the end of the year, I will have to reconcile this. So if my income changes or if my estimate was wrong, then I may have to pay back some of that tax credit, or I may get more back at the end of the year. Because of the tax credits, most people, 70% of people on the marketplaces, are spending less than $100 a month, which is huge. It's also worth noting, lawfully permanent residents of less than 5 years, so they don't qualify for Medicaid because they haven't met the waiting period, can get tax credits even if their income is under 100% of the federal poverty level because they can't get into Medicaid. So there is an extra protection. However, they're treated as if their income is 100% FPL. So it still may not be affordable for them. Cost sharing reductions are the second type of financial assistance available to a slightly smaller group of people. Anybody with income up to 250% of the federal poverty level can get this financial assistance, which decreases the charges associated with accessing care. So you have co-payments, deductibles, co-insurance. Those are the costs when I actually go to the doctor, when I actually need services. So same kind of thing. This is based on my income right now, and when I go to the doctor, I may have a co-payment for primary care visit of $40 for my plan. But because I have the cost sharing reduction, I might only pay $5 or $10 or $15. And the federal government is going to send the rest to my insurance carrier, who's going to pay my provider. So providers still get the same amount, but some of that is paid by the federal government. At the end of the year, if my income is different from what it was when I signed up for the plan, I don't have to reconcile this. Because this is associated with my ability to pay today, it is going to be given to me today, and I'm not going to have to give that back at the end of the year if I get a raise or a new job. Of course, the other part of this is Medicaid, and this is really important since more than 50% of people who are currently uninsured qualify for Medicaid under the expansion. So before the Affordable Care Act, Medicaid is a state federal health insurance program. So the federal government provides financial support to states wishing to participate in Medicaid, but that money is tied to certain rules, right? So if a state participates in Medicaid, they have to cover certain populations, they have to cover certain services. States can go above and beyond that, and sometimes there's additional support to states that do that. For example, family planning waivers provide family planning services to women and men between 19 and 44 years old typically, or 15 and 44 I should say. It includes things like birth control, but also sexually transmitted infection screenings and treatment. That is something that states can take on, and the federal government will give them extra money to do that. Then there are things that states do even though the federal government doesn't help to pay. So for example, the federal government, if states want to participate in Medicaid, the federal government requires that they cover children. They cover children up to a certain percentage of federal poverty level, and they can only use that money to cover lawfully permanent residents of 5 years or more. So kids who have been in the country legally for 5 years or more. In Illinois and in many other states, we know that that's a significant barrier for kids, and no one wants to see kids unable to access care. So in Illinois, we cover the costs of children who do not meet the immigration requirements established by federal law. So undocumented children and children who are lawfully present of less than 5 years are covered in the All Kids program 100% of the cost falls on the state. So you have that sort of flexibility. Federal Medicaid funding accounts for 10% of most state budgets, so all states participate in Medicaid even though it's a voluntary program, and it's because of that significant financial contribution. On average, money spent by states on the federal government by states on Medicaid is far less than the money contributed by the federal government. Programs vary very much from state to state because of that flexibility. We see differences in eligibility levels, we see differences in coverage levels, we see waivers and other programs reshaping Medicaid in different states. That's great in some ways because it allows us to be more innovative and learn from new models. In other ways, it's not so great because it creates a tiered health system, especially in some of those states that are less likely to support their lowest income residents. Coverage goes only to qualified individuals with federal funding. So again, states can expand using their own money. So you have to meet income eligibility guidelines, and this is different for all different groups. You have to meet immigrant eligibility, so lawfully permanent resident 5 years or more unless your state expands with their own funding. And you have to meet categorical eligibility. So you have to be a child, a pregnant woman, a custodial parent, elderly, or disabled. Before the ACA, if you're not one of those 5 categories, it does not matter what your income is. There was no federal support for you in Medicaid, and most states didn't cover you. So you have all these low-income, childless, non-disabled adults who are left uninsured even though they're very low income. So the Affordable Care Act expands Medicaid, and I'm actually going to skip ahead to this slide and show this. So Medicaid is our umbrella, right? And we have different buckets underneath the umbrella. This red section is Medicaid eligibility before 2014, so before the Affordable Care Act. And we have certain buckets of people, like I said, elderly, disabled, children, pregnant women. What the Affordable Care Act does is it expands the umbrella out to cover childless, non-disabled adults, under 138% of the federal poverty level. So this brings in a lot of people. In Illinois, it's almost half of our uninsured. We've already enrolled about 300,000 people into Medicaid expansion in Illinois alone. It creates an important pathway to coverage. Unfortunately, the Supreme Court decision in 2012 changed the way this is implemented. So the law said any state choosing to participate in Medicaid, which we know is all states, must expand coverage to the newly eligible population. States challenged this because they didn't want to cover those individuals because they felt there would be a cost burden. Even though the federal government pays 100% of costs for the first 3 years, eventually states would have to pay about 10% of costs. And they didn't feel like they could say no, because if a state said, no, I don't want to cover these folks, they lost Medicaid entirely and none of these people were covered. And about 10% of that state budget was suddenly gone. So states challenged a number of things. They challenged the requirement to purchase coverage. They challenged a lot of other big pieces of the ACA, and they challenged Medicaid expansion. In that Supreme Court decision, we were fortunate in that the law was upheld, the individual mandate was upheld, and for the most part, the law was left intact. The only decision that ran counter to the administration and has a significant impact on how this law is playing out is that the Medicaid expansion was made optional. The Supreme Court decided that because of the money on the line for saying no, this amounted to federal coercion. And so states needed to have the authority or the opportunity to refuse Medicaid expansion and still cover all of these populations. So Medicaid expansion became optional. About half of states have expanded. A number of states expanded right away, but you can make some guesses about the states that are left that haven't. Or you could go to the news, right? Every day we see more and more states moving towards expansion. We expect this year there will be at least 5 states that expand, and it is a widely held belief that within 5 to 6 years, every single state will expand Medicaid. We're getting close to the point in time where it's really a contest to see who's going to do it last, rather than whether or not everybody's going to do it. The reason this is happening, the reason states are ultimately making the decision to move, is because the law was really designed as a puzzle. So using our umbrella metaphor again, we have all of these uninsured people, and we needed to cover them with the umbrella. Now, we left out undocumented, but we have Medicaid for specific groups, our old Medicaid coverage. We have our marketplace financial assistance, which you'll remember only comes down to 100% of the federal poverty level. In states that expand Medicaid, like Illinois, we have coverage for people in the middle because of Medicaid expansion. These are people with incomes under 100% of the federal poverty level, who have not typically qualified for Medicaid. In states that don't expand Medicaid coverage, that's a gap. So if I have income at 100%, I can get on the marketplace and I can get financial assistance. If I fall into categorical eligibility, I can get into Medicaid. But if I don't meet categorical eligibility, if I am the poorest among us, under the federal poverty level, I fall into the gap. And this is a huge problem for those states facing gap. This is the biggest policy decision at the feet of most states right now, is whether or not to expand Medicaid. And again, I think we will see 100% expansion in the next 5 to 6 years. So that's how we created coverage, but it's important to think about the timeline because the ACA really gives us a lot of dates to remember. So open enrollment for the first year was October 1st through March 31st. We added a little extension to April 15th because of problems with the website. So what happens now, right? So if I qualify for Medicaid, I can enroll year-round. That's true everywhere. Medicaid enrollment has always been 365 days of the year. If I have a life event, so if I graduate and lose coverage, if I get a new job, if I move, if I get married, if I have children, or if I have a complex application issue. So for this year only, because of problems with rollout, if you couldn't get through on healthcare.gov or your state marketplace through no fault of your own, in either of these instances, you get a special enrollment period. So this is the cycle we're going to move into. Periods of open enrollment where everybody can make changes. And those are going to be relatively short, looking at about 3 months when we level out. And then periods of special enrollment. A lot of people are going to get special enrollment periods, and we're already seeing a ton of those. But it's important to know that right now you only get coverage in those special enrollment periods. There's a great screener on healthcare.gov if you're wondering if you qualify for a special enrollment period. If you don't qualify for a special enrollment period, if you don't qualify for Medicaid, then you have to wait for the next open enrollment period to begin. So the next one begins on November 15th and runs through February 15th. This is still a little bit longer than it will be in the future. There are some big policy conversations around this. Not necessarily the length of open enrollment. It should be short because we need people to act, and people don't act without deadlines. But advocates would really like to see open enrollment aligned with the tax period, the tax season, because that's the single largest transaction most people will make in a year. And they can take that money and move it into their health insurance premiums if they have a return. Our tax specialists also then become our outreach specialists. They can help to have those conversations. This is also really easy because the individual mandate, that requirement to have coverage, if you pay the penalty, you're paying it with your taxes. So you're already having these conversations. So we could see some movement for future enrollment years, but for sure next year we'll start November 15th. So the last thing I want to talk about is the actual enrollment, because this is what the media is talking about. This is what people are hearing. This is how we're sort of measuring in the short term whether or not the Affordable Care Act was worth it or if it's working. I don't think it's fair to measure the Affordable Care Act entirely on enrollment because of all of those protections in place. What we really need to be looking at in the long term is health outcomes. And does this really create better access to health care? That's when we can talk about success. But short-term measures of success absolutely include those who have become covered. And we have done a very good job, though you may not have been led to believe this. The Congressional Budget Office estimated that 7 million people would enroll in state and federal marketplaces in the first open enrollment period. We essentially lost 2 months of enrollment because of the disaster that was healthcare.gov. States like Oregon have not enrolled anybody on their marketplace because it was so bad. So healthcare.gov wasn't even the worst. Yet, over 8 million people selected plans. So we actually exceeded enrollment goals by about 1 million people. Insurance companies are telling us about 90% of these folks did pay their premiums, and there's still time for people to get caught up. You don't pay your premiums right on the marketplace, so it's harder for us to have that data. We do know that 46% of the 8 million are men. That's huge because men are much less likely to carry health insurance or access care effectively. 28% are between 18 and 34, so we got those young adults we needed. 65% selected a silver tier plan. So on the marketplace, we have bronze, silver, gold, and platinum. Silver plans are the plans you must select if you want cost sharing reduction. So this indicates that a lot of people have gotten that additional assistance. 85% of people have some sort of financial assistance. So they may have the cost sharing reduction, or they may have a tax credit, which you can use to purchase any plan. Huge, huge, huge We did not expect that many people to take financial assistance, and it shows just how much need there was for an affordable health insurance option. On the other side, we have Medicaid and Children's Health Insurance Program enrollment. These numbers come from Health and Human Services, and they are likely very low because most people are not going to a marketplace to enroll in Medicaid. They're going right to a Medicaid office, or they're going through the SNAP program or other places. So we can only report those people who come to the marketplace. But we know at least 6.7 million people started their applications on the marketplace and were then transferred to Medicaid. The reason we know this is much higher is because in Illinois alone, we've received something in the neighborhood of 500,000 applications. So there's no way if Illinois has 500,000, we only got 6 million. The estimates are that we're much closer to 10 million in terms of Medicaid and CHIP enrollment. Kids were always eligible for CHIP. CHIP eligibility didn't change, but just like with all Medicaid programs, we have this welcome mat effect. When you start talking about health insurance and getting Medicaid publicly and frequently, it is highly likely that people who were always eligible but not enrolled are going to come out to see what they can get and enroll in programs they always could have had. We're seeing that in every state. The bigger story is looking at the rate of uninsured adults. And this is actually not even the most recent chart anymore. This comes from Gallup, the polling people. They've been talking to adults since 2009 to ask them about their rates of uninsurance. So what we know is in the first quarter of 2009, our uninsured rate among adults was about 14.4%. Then, of course, things climbed and climbed and climbed, as the uninsured rate often does, and especially in the context of the recession. And we hit this peak of 18% uninsured right around the time that the marketplaces opened up. Now we are down, actually as of the second quarter of 2014, we now have this data, we're down to 13.4% uninsured. That's a lot more than this many people, right? That's because people got insurance in a lot of other ways. If I didn't qualify for financial assistance and healthcare.gov wasn't working, I could just go to Blue Cross Blue Shield or Humana and buy the same plan directly from them. It's more likely that my employer was offering coverage. It's more likely that I accepted coverage from my employer or from my spouse or from my school because of the individual mandate. We're going to continue to see a downward trend in the uninsured rate among adults, and that is huge. And looking at a chart like this is much more important when we think about enrollment in the Affordable Care Act. We have a lot of opportunities, a lot of policy decisions which must be made in the coming years. These are some of the most immediate that advocates like myself are talking about. So expanding Medicaid in states that have it. Establishing state-based marketplaces. Through the end of this year, there's still funding available to states to do that if they wish, and many states are considering. We can talk about immigrant eligibility. Can we expand coverage to cover more immigrant families or even undocumented families at the state level or at the national level? It's going to be important if we really want to move health outcomes and drive down the cost of healthcare for all of us. Affordability. So there are a lot of different options to make coverage more affordable. The two most concrete are to look at our deductibles. We need to bring those down and find ways to incentivize insurance plans to bring those down, even though that may mean increasing premiums slightly. We can look at something called the Basic Health Plan, which creates a bridge for people who are phasing out of Medicaid because their income has changed and creates a very, very inexpensive health insurance program that's a public-private partnership for people up to 200% of the federal poverty level. Only a few states have started doing this. It's a state option, but I think we'll see more and more take it up. So we'll be watching states like New York and Minnesota to see how it works. We also need to think about the bigger picture of affordability, like I mentioned before, looking at why healthcare costs what it does and how we can address that. Want to look at benefits? We can always improve our standards, improve our essential health benefits, and monitor implementation so we can watch and say, okay, this is the standard that the law establishes, but is that actually happening? And if not, what can we do to fix it? And finally, we can monitor the impact. Over the next 5 to 10 to 20 years, there are tremendous research opportunities for people interested in the impact of public policy, in public health, in a whole host of issues, because we can really see what difference it makes to implement such a large program, and then what difference some of these tweaks make in different states. Even though this is a federal law, it looks very different in most states. That creates a natural experiment for us to see how the people of those states are affected. So just a few resources to share. Illinois Health Matters is the website I mentioned earlier. Great resource if you're looking for Illinois-specific information. They have a really great blog. Enroll America is a national organization devoted to outreach and enrollment, or outreach and education for the Affordable Care Act. They've got a lot of great resources to help you understand who the uninsured are, what they want from a policy, and how they're reacting to the marketplaces, to Medicaid and other parts of the Affordable Care Act. Kaiser Family Foundation is just a great think tank with tons of health information, including information about health reform. Young Invincibles talk about policy issues impacting young people specifically, and could be great for, have a lot of information about the Affordable Care Act. And finally, Get Covered Illinois. This is the marketplace in Illinois. If you live in Illinois and you're looking for coverage, this is where you'll want to start. You can go here to find support enrolling as well. So we have a network of navigators who are granted to provide free enrollment assistance to people who need it. You can also call this phone number, 866-311-1119. And finally, my contact information. I know I'm not here with you, but please feel free to reach out to me if you have questions, if something doesn't make sense. My email is on here, and my phone number. You can also find me on Twitter, Waligora. Ask me questions however you feel comfortable. Thank you.